Welcome to Ultrasound-Guided Neuraxial Block. Background information and gross anatomy. Spinals and epidurals are critical procedures in the anesthesiologist's toolbox. Neuraxial blocks represent a mainstay of anesthetic techniques. Neuraxial blocks may provide a survival benefit in certain populations when compared to general anesthesia. For many surgical procedures, such as total joint arthroplasty, patients can completely avoid general anesthesia. Spinals and epidurals can be difficult. Ultrasound allows us to find the midline, find open interspaces, pick appropriate needle length, and even predict difficult procedures. The key to spinal ultrasound imaging is to understand that acoustic windows are where you want your needle to go. Acoustic windows occur where there is no bone to block ultrasound transmission. This is a labeled model of the spine. The yellow arrows indicate the interspaces that one would want to target for either a spinal or an epidural. They also represent the acoustic windows that you will search for with ultrasound. Here is another anatomical model with the spinal cord in situ, demonstrating its relationship to these acoustic windows. If we flip this model over and look at the anterior aspect, we see some very important structures. We will want to image these structures with ultrasound. They are the disc, the vertebral body, and the posterior longitudinal ligament, which is not labeled in this model. In this image, we have now labeled the posterior longitudinal ligament as a yellow line. Please note its relationship to the spinal canal. The anterior complex. If the ultrasound beam can image structures anterior to the spinal cord, then there should be a clear path for the needle to puncture the dura in the case of a spinal, or be placed epidurally in the case of an epidural. In other words, there should be no bone or metal in the way. These anterior structures will be referred to as the anterior complex and may represent either the posterior longitudinal ligament, intervertebral disc, or vertebral body. Now, let's take a look at the ultrasound anatomy. The first view will be the parasagittal long axis view, otherwise known as the paramedian view. The image on the left is a model of the lumbar spine. The dotted red line indicates the direction of the ultrasound beam as it relates to the bony structures of the spine. The image on the right is the corresponding ultrasound image. You can see the lamina of L2, L3, and L4. You can see the dropout shadow beneath L3. Note the anterior complex is a hyperechoic linear structure that is found between the lamina. These would be considered open interspaces using a paramedian technique. The next view is called the transverse view, otherwise known as the short axis view. Once again, the image on the left is a model of the lumbar spine. The dotted line represents an ultrasound beam that cuts through the facet joints in short axis, the transverse view. The corresponding ultrasound image is seen on the right. The facet joint is indicated by the red circles. The anterior complex is seen as a hyperechoic linear structure on the bottom of the ultrasound screen. Take this time to look back and forth between the transverse view on the model with the ultrasound image and make sure you can identify all of the various structures. The yellow dot indicates the approximate location of the spinal cord in relation to these other structures. The dura would be located slightly posterior to this yellow dot. If you move the transducer slightly caudad or cephalad from the prior transverse view, imaging through the facets, you will then image the spinous process, and the ultrasound will be blocked from reaching the spinal cord, generating a distinctive image. This concept is demonstrated here. Note that the dotted red line now indicates that the ultrasound beam is trying to penetrate at the level of the spinous process. This generates this distinctive image on the right, where you can see the spinous process as a hyperechoic structure, the two lamina, and the dropout shadow. No anterior complex can be seen. We have placed these two ultrasound images side by side to illustrate their differences. The location on the spine from which these images were generated is demonstrated by the dotted red line. Once again, the top image represents the interspace, the location at which you would want to place your needle. You can see the anterior complex clearly in this image, but you cannot see it in the lower image because the ultrasound beam is being blocked by the lamina. Ultrasound equipment. The linear transducer, seen on the left, is the most commonly used transducer for regional anesthetic techniques. However, for neuraxial imaging, a curved transducer is preferred. A curved transducer allows for better penetration in a wider perspective on associated structures. Procedural steps. This technique is known as the marking technique. You will use an identical position as you would to perform a spinal or epidural. Scan in a parasagittal plane, the paramedian direction, to identify and mark open interspaces from the sacrum to the lumbar level of preference. Then scan in the transverse plane to identify and mark the midline. Then simply connect the dots. We will now demonstrate this in images and video. Using a parasagittal view, identify the L5-S1 interspace. The sacrum is easy to see because it is a long, linear, hyperechoic structure. The image on the left demonstrates the parasagittal view cutting across L5 onto S1. This is indicated by the dotted red line. The corresponding ultrasound image is on the right. The L5 lamina is labeled with a dropout shadow. The sacrum is easily identified as a long, linear, hyperechoic structure. Mark the interspaces by centering the anterior complex in the middle of the ultrasound screen for each level. This is now demonstrated in the video. The anterior complex at L5-S1 is indicated here. When this anterior complex is in the center of the ultrasound screen, simply mark the middle of the transducer with a horizontal line. Then move the transducer to the next level, repeating the process with the anterior complex in the middle of the screen. Repeat this process so that you cover at least 3 interspaces. These horizontal lines represent the topographical location of the interspaces. We still need to identify the midline based on the location of the spinous processes. This is demonstrated here. The transducer is moved to generate a transverse view. Remember, at the level of the spinous process, there should be no ultrasound penetration. A dropout shadow blocks any view of the anterior complex. This represents the midline of the spinal column. This principle is demonstrated here. The dropout shadow is indicated. The spinous process is indicated as well. Note that you cannot see the anterior complex because the ultrasound beam is being blocked. In a similar fashion to the parasagittal view, mark the middle of the transducer with the spinous process centered in the middle of the ultrasound screen. Do this for several levels. Then simply connect the dots. You now have the interspaces marked as horizontal lines. The vertical line represents the midline of the spinous column. I have labeled L5S1 here. Now, with the interspaces marked in the midline noted, simply proceed as normal with your spinal or epidural. It is important to note that you should target interspaces where you see the anterior complex easily. This is because that interspace is likely open and not impeded by bone or other pathology. Often, a patient cannot be placed in the sitting position to perform a spinal using the marking technique. If a patient is in the lateral position, you can still perform the marking technique in an identical fashion as compared to a sitting patient. Of note, you will not have access to the dependent side for imaging. Additionally, the imaging and marking may be ergonomically more challenging. Clinical pearls. Again, choose an interspace where you can see the anterior complex. You can use your calipers to measure approximate depth to the epidural space. This may be helpful in planning your needle selection or when you anticipate you should acquire CSF or loss of resistance. Typically, the L5S1 interspace is the most likely to be open based on ultrasound information. If you cannot identify any anterior complexes despite imaging at all levels, the spinal will likely be difficult or impossible. Although possible, it is very difficult to consistently identify the dura with ultrasound. In morbidly obese patients, the imaging goal may simply be to identify the midline. A few additional points regarding morbid obesity. You should use lower frequency ultrasound settings. This will allow better penetration of the tissues. This topic is discussed in more detail in the Introduction to Ultrasound-Guided Regional Anesthesia video available on McGraw-Hill AccessAnesthesiology website. You should also increase the gain and also set the focus to a deeper setting. One recommended strategy is simply to search for dropout shadows as helpful clues for identifying the midline location.